my clinical diagnosis. My clinical diagnosis of this middle-aged gentleman is chronic liver disease, evidenced by leukonychia, along with clubbing, and also I have found few spider nevi on front of the chest, and this chronic liver disease is decompensated, uh, evidenced by jaundice, or flapping tremor, or ascites, whichever is present. Um, Ascites, as I have found the shifting dullness and also fluid fill, and this CLD is complicated by portal hypertension, as I have found splenomegaly, which is about 3 fingers breadth from the left costal margin, and also and along with that, I have found maybe anemia, if there is upper GI bleeding, and hepatomegaly may be also present if it is early stage. আর ভাইয়া cause wise যদি কোনো finding থাকে for viral hepatitis, any tattoo, any needle prick mark, এগুলো দেখবো। তারপরে
actually আমি তোমাকে মানে বলেছিলাম যে একটা প্রেজেন্ট কমন একটা প্রেজেন্ট করার জন্য
স্পেশাল কোনো কিছু।
So if you want to present a case of actually CLD, CLD is a very common presentation in PACEs, actually in abdomination. So there are certain actually ways, and before starting any presentation you need to tell few lines, like to complete my examination I'd like to examine the external genitalia, the hernial orifice, and do digital rectal examination. In certain circumstances you can say that I would like to do also bedside urine or bedside blood glucose test. So in case of CLD you can start with the periphery. Okay, you can say this gentleman, examination of this abdomen of this gentleman ribis, he has pulmonary erythema, spider nevi on the neck or chest, there might have some gynecomastia and reduced health distribution, all may not present at a time. Okay, at first you can say about the stigmat of chronic liver disease, he has pulmonary erythema, suppose this gentleman has pulmonary erythema, we block it, and he is icteric, and there is abdomen is distended, flanks are full, there is this hepatomegaly or hepatosplenomegaly, as evidenced by liver is enlarged 3 centimeter from 3 fingers from right costal margin, the right mid clavicular line, the spleen is enlarged from left costal margin 2 centimeter from the left mid clavicular line towards the umbilicus. So you need to describe this like that, and there is evidence ascites as evidenced by shifting dullness. If when you find shifting dullness, you don't need to do any fluid trill. Okay, so in which circumstances we should do the fluid trill? If the abdomen is tensely distended, then we can do fluid trill. Other than that, we will go for the shifting dullness. We need to keep it in mind. Okay, suppose we have find shifting dullness in this patient, then we can comment on probable etiology. Suppose this patient has tattoo mark, okay, which might indicate a chronic hepatitis B or C infection. So my diagnosis is decompensated chronic liver disease, most probable etiology. If you say the splenomegaly, then you can say with portal hypertension. So the presentation would be like that. Examination of the abdomen. To complete my examination, I would like to examine the external GLTS, see the hernial orifice and do the digital examination. Examination of the abdomen of this gentleman reveals he has primary erythema, he is icteric, there is a hepatosplenomegaly as evidenced by dash and evidence of ascites evidenced by shifting dullness. Patient has tattoo mark on his left or right arm. So putting all this together, my diagnosis is a case of decompensated chronic liver disease with portal hypertension. Most probable etiology is chronic viral hepatitis. Okay, Dr. Maisha.
জি ভাইয়া
তাহলে প্রেজেন্টেশনটা এরকম করতে হবে, তুমি যেভাবে করছো সেটা হবে না কিন্তু। হ্যাঁ, মানে ইউ জাস্ট লাইক তুমি ছাড়া করতেছিলা প্রেজেন্টেশনটা, এগুলো হবে না। ইউ হ্যাভ টু ডু লাইক দিস, যে তুমি এভাবে বলে। বাট এই যে আমি যে ব্র্যাকেটে এগুলো দিছি, দিস আর নট, এগুলো বলতে হবে না, বাট আমি জাস্ট এগুলো মনে রাখার জন্য। তাহলে তোমাকে কি কি বিষয়ে কমেন্ট করতে হবে? What features actually you need to tell during your presentation? Stigmata of CLD, features of decompensation, and probable etiology. Okay, you need to ask about this, and also associated stigmata and splenomegaly, and also you need to actually keep in mind about the portal hypertension also. So this is how actually we should present a case of chronic liver disease. Okay, do you have any questions regarding this case? Okay, there might have other indication, okay, of probable etiology, like if the patient has parotid enlargement or Dupuytren contracture, we can think about alcoholic. If the patient has hyperpigmentation, hemochromatosis might be the cause. If the patient is young and has cave ring, then we can consider Wilson disease. Actually, I need to apologize to you because actually this was typed by a non-medical person. That's why there might have some spelling mistakes. Okay, disease. Okay, next case, isolated hepatomegaly. Actually, we showed few cases of isolated hepatomegaly. So I want to actually ask someone to describe a case of isolated hepatomegaly. Dr. Rini, are you there? Can you describe or if present a case of isolated hepatomegaly?
Okay. On examination,
to complete my examination, just actually start with that.
Okay. Okay, to complete my examination, I would like to do I would like to check for hernial orifice, do external genital examination, and also like to do the digital rectal examination. And on examination of this man, I found that that he is cachexic. The abdomen is not distended, and there was hepatomegaly with which was palpable like 3 centimeter from the right costal margin in the midclavicular line towards the right iliac fossa, and the margins were well defined with a with firm surface. There was no splenomegaly, no ascites, and there was no hepatic bruit, and there was no lymphadenopathy.
What is your diagnosis?
So putting this all together, my diagnosis is this is a case of chronic liver disease, most probably viral hepatitis.
Okay, but you are saying that the chronic liver disease or acute liver disease?
Acute liver disease.
Or chronic? Which one?
Acute.
But in case of acute, there actually patient should have jaundice, right? First of all, that, and it should be tender. and you need to actually
Tender,
you
right.
need to tell about this. So suppose this patient is non-tender and he doesn't have any jaundice. So what might be the cause?
Alcoholic liver disease.
Okay, alcoholic hepatitis. Okay, anything else?
Non-alcoholic fatty liver disease.
Yes, good. Anything else?
Amyloidosis হবে
Painful.
Amyloidosis with rare diagnosis. Anything else? Like if a patient with isolated hepatomegaly, so there are certain causes we can consider. If the patient is non-icteric, so we can consider primary hepatocellular carcinoma.
cystic liver disease
Sorry.
cystic
Yes,
carcinoma.
yes. Primary hepatocellular carcinoma secondaries, right? From the any other parts like colon, cystic liver disease. Okay. Then we can consider some causes of chronic liver disease, like you said, alcoholic chronic liver disease, non-alcoholic fatty liver disease, hemochromatosis. But chronic viral hepatitis does not cause hepatomegaly. But if the patient has chronic liver disease and on top of that there might have some malignancy, right? Hepatocellular carcinoma. Then you can say, in case of chronic viral hepatitis, you can say hepatomegaly. But without hepatocellular developing hepatocellular carcinoma, chronic viral hepatitis usually liver becomes small, actually shrunken, right? So in such circumstances, in case of hepatomegaly, actually the list should be hepatocellular carcinoma, primary or secondary, cystic liver disease, and CLD due to alcoholic liver disease, non-alcoholic fatty liver disease, hemochromatosis, such and such, and also acute viral hepatitis, usually tender. I've already told that. Usually this is tender and patient has jaundice, right? If that present, then you can consider. Okay. Other than that, in case of, and you have already said that this patient is cachectic, so it cannot be acute hepatitis, right? Okay. Okay. Do you have any question regarding this isolated? I think you have seen some cases of isolated hepatomegaly. Okay. So this is another type of case. First case was discussed is CLD. Sometimes it may be decompensated. Sometimes may be compensated. So most of the cases in exam you might find decompensated. You might find the features of decompensation. What are the features of decompensation? Flapping tremor, or jaundice, or ascites. These are the features of actually decompensation. Yes, encephalopathy, flapping tremor. If you find this feature, then you must say that this is a decompensated chronic liver disease. If you find that ascites, you must say there is portal hypertension, right? Okay. Now another case, splenomegaly or hepatosplenomegaly. We actually consider this same entity.
I have one question regarding isolate.
Okay. Ask.
Hello.
Yes. Tell. What is your question, Dr. Noyon?
Question regarding isolated hepatomegaly. So in isolated hepatomegaly, is it tender? Yes, there is tender and non-tender hepatomegaly. So for tender hepatomegaly, who is different?
Yes, sometimes primary hepatocellular carcinoma may be non-tender. Okay. And in sometimes acute viral hepatitis may be non-tender in resolution phase. So if you said a patient with cachectic patient with hepatomegaly, if you said that it's primary hepatocellular carcinoma, actually it will not be wrong. Okay. And to differentiating between primary and secondary hepatocellular carcinoma, you have to actually appreciate the surface. In case of secondary, the surface will be nodular, right? So
yes,
you need to keep it in mind. And Is that okay? Do you have any other question?
Okay, I'm just asking that for non-tender hepatomegaly differential, I have to keep in mind.
Yes, in case of non-tender, secondaries, if the patient is cachectic, but if the patient is not cachectic, you can first start with CLD due to alcoholic liver disease, non-alcoholic fatty liver disease, hemochromatosis, and cystic liver disease, then secondary.
Okay.
If the patient is cachectic, then you should start with secondary first, then you can say CLD, cystic liver disease.
Okay, thank you.
Okay, actually with splenomegaly and hepatosplenomegaly, both the causes are the same. That's why they are grouping grouping same para. So I would like to ask someone to describe such cases. And who is there to describe? Dr. Farah?
Yes, Bhaiya.
Can you describe a prototype of case of splenomegaly or hepatosplenomegaly?
Sorry, Bhaiya.
Can you present the case of hepatosplenomegaly?
Okay. Examination of the abdomen of the patient shows that there is a it shows that spleen is enlarged, 2-finger breadth from the left costal margin towards the umbilicus. And spleen is, should I describe the surface and the border?
In case of spleen, you can say that there is some notching. You can say this, but in case of spleen,
Okay.
border surface is not that much important. But liver, this is important.
Okay. So so there is the splenic notch is can be felt, and also liver is enlarged 5 centimeter 5 centimeter from the right costal margin along the mid clavicular line, and the liver is non-tender, and upper border of the liver dullness is at 6 intercostal space. So I have so the differentials maybe it can be chronic myeloid leukemia, then
Okay.
it can be any myeloproliferative disorder. Then
Okay, this is actually also chronic myeloid leukemia is a myeloproliferative disorder. Okay, other myeloproliferative disorder.
then
Anything else?
It can be due to hepatosplenomegaly, malaria, Kala-Azar.
Okay, chronic malaria, Kala-Azar. Then
Chronic malaria, chronic Kala-Azar. Then I think that's it.
how about the patient is young? In that case,
Patient is young.
what will you consider?
Sorry, I can't.
Okay, we'll discuss it later. Okay, thank you. Good. So examination of the abdomen or is of this gentleman, or examination of the gastrointestinal system of this gentleman reviews. তার আগে আমি কথাটা বলে নিব যে to complete my examination this there is a hepatosplenomegaly as evidenced by liver is enlarged 4 fingers from the right costal margin, non-tender from right mid clavicular line. You can say about this, and spleen is enlarged 3 fingers with from left costal margin towards the umbilicus. I have some differentials for that. If elderly patient, if the patient is elderly, suppose you have seen the patient is elderly, then you can say myeloproliferative disorder like CML myelofibrosis, polycythemia rubra vera. Okay, if the polycythemia is present, then you can tell about chronic malaria and kala jar. Then lymphoproliferative disorder. If we find the lymph node, okay, CLD with portal hypertension may also present with hepatosplenomegaly. In some instances, CLD, actually hepatocellular carcinoma on top of CLD with portal hypertension can also present as hepatosplenomegaly. Hereditary hemolytic anemia, but it mostly applicable in case of young patient. In our country, many teachers actually want to know about tuberculosis, disseminated tuberculosis. Or you can also consider ACLE. ACLE also may present like that, but these are very rare. In patients, actually try to avoid use this diagnosis. So in case of elderly patient, we'll consider myeloproliferative disorders, AML, myelofibrosis, PRV, if polycythemia present. If polycythemia doesn't present, you should not actually tell PRV. Malaria and kala jar is common, and you can use this in young patient as well as elderly patient. And lymphoproliferative disorder, mostly actually lymphoproliferative disorder can actually occur in both type of patient, young and old, CLD and portal hypertension. Okay. And if the patient is young, hereditary hemolytic anemia, especially if the patient has anemia and jaundice and associated with mongoloid facies, and then hereditary hemolytic anemia will be the first diagnosis. Then we can consider lymphoproliferative disorder, because we know that Hodgkin lymphoma has actually young onset or bimodal distribution. So we can consider lymphoma, malaria, kala jar, also CLD with portal hypertension. Myeloproliferative disorder actually happens less likely in case of young patient. So you need to actually keep in mind in that list of differentials. Anybody has any question regarding the presentation and also differentials of isolated splenomegaly or hepatosplenomegaly? If you find the isolated splenomegaly, the differentials will be the same. If you find the isolated splenomegaly in the young patient, differentials will be the same. So do you have any question regarding this? So let's proceed. Sometimes in some cases, actually ascites actually so huge that it is very difficult to appreciate the organomegaly. So what might be the differentials in that cases? So I can ask one to describe a case of isolated ascites. You can say that only ascites you have find only as huge ascites. Okay. So Dr. Mitu, are you there?
Yes, Bhaiya.
Okay, can you present a case of only ascites?
Yes.
Okay, present.
So I would like to complete my examination by taking detailed history and doing bedside urine test, and also doing the digital rectal examination. And I have found that the after completion of the abdomen examination, I have found that his abdomen is distended, flanks are full, umbilicus is everted, and there is ascites, which is evidenced by shifting dullness, but I couldn't appreciate any underlying organomegaly, and there is no other peripheral stigmata of chronic liver disease.
Okay.
So my clinical diagnosis, it's the case of ascites, and I have some differential for it.
Okay, what are your differentials?
My differentials are it may be a case of decompensated chronic liver disease, and it may be a case of malignancy with peritoneal metastasis, or it may be a case of abdominal tuberculosis, or it's a case of nephrotic syndrome.
Okay, good, excellent.
Mm,
Yes, but
I
in
believe that's all.
in your cases, actually during your initial presentation, you need to tell about not only digital examination, also as you differential CLD, you need to examine the external
Yes.
genitalia, right? Okay.
Okay. Yes. Digital external genitalia and digital rectal examination.
Examination of the abdomen of the gentleman reveals he has ascites as evidenced by abdomen distended and presence of shifting dullness. Okay. And my differentials, the decomposition chronic liver is intra-abdominal malignancy with peritoneal metastasis. Abdominal malignancy with peritoneal metastasis, intra-abdominal tuberculosis, rare case. If the examiner push you, you can say there are certain rare causes like nephrotic syndrome, acute pancreatitis, and congestive cardiac failure also presented with. But in that cases, there will also have some leg edema, bilateral pedal edema. But in case of isolated, only isolated hepatomegaly, you need to consider these three. Even if you don't, if you don't get any stigmata of chronic liver disease, and the patient is not cachectic, no abdominal mass, so in that circumstances, only ascites, the decompensated chronic liver disease will be the first diagnosis. Okay, now move on. Another case, polycystic kidney disease. This is also common case in Indian center like Chennai or Hyderabad. So you need to prepare yourself for this. So I can ask one, Dr. Noyon, are you there?
Yes, sir.
Can you present a case of polycystic kidney disease?
এটা আসলে প্রিপারেশন নাই, মানে এটা
This is very easy. Okay.
দেখছি একবার শুধু।
Acha. Okay, you can try, but if you don't want to try, I can give chance to another candidate. Okay, Dr. Mehjabin. Or Dr. Akhi. Okay, Dr. Mehjabin. Okay. Can you present?
Sorry, yeah, the polycystic kidney disease.
Yes.
Okay. To complete my examination, I need to examine the hernial orifices, external genitalium, and perform DRE. On examination of this gentleman, his kidney was found enlarged. It was also palatable. There no renal bruit was present.
Okay. So what is your diagnosis?
My diagnosis is bilateral polycystic kidney disease.
Any differentials you have?
Differentials, it can be a case of splenomegaly একটা আসে differentials এ, কিন্তু সেটা তো হচ্ছে যে some differentiating points দিয়ে ওটা আমরা
So,
যে splenic
in case of
notch
splenomegaly, it will not be ballotable, right? It will not be ballotable. So, what are the other causes of polycystic? You can say that like you can say that bilateral hydronephrosis, bilateral renal cell carcinoma.
থাকে, তারপর হচ্ছে কোনো টিউমার যদি থাকে।
Bilateral renal cell carcinoma. These are the differentials. Okay, thank you. So can anyone present a case of ESRD, intestinal disease, Dr. Akhi? Or Dr. Farhana Japa?
হ্যাঁ ভাইয়া আসি।
Okay, please try to actually present a case of ESRD.
আচ্ছা ভাইয়া। I want to finish my examination by doing checking external genitalia and by doing digital parectal digital examination. On examination of the abdomen of this gentleman,
Okay, proceed.
On the left the neck and upper chest that that indicating that previous mode of renal replacement therapy. And there is also a bilateral ballotable kidney, and patient has no edema.
Okay.
So my diagnosis, probable diagnosis that end stage renal disease due to autosomal dominant polycystic kidney disease, and dialysis and adequate evidence.
ওকে, কেটে যাচ্ছিল একটু একটু করে। এনিওয়ে, ভালোই বলছেন আপনি। অ্যাকচুয়ালি ইউ হ্যাভ সেড দ্যাট। Okay, so presentation of ESRD is examination of the abdomen of the gentleman ribs. There is a functioning fistula on left wrist, elbow, or even shoulder. Shoulder থাকতে পারে যদি wrist and elbow গুলো fail হয়। Multiple scar marks over the neck and upper chest indicating previous form of renal replacement therapy. There are bilateral ballotable kidneys. Patient has no edema, so my diagnosis is a case of ESRD due to ADPKD. Dialysis is the current mode of renal replacement therapy, which is educate. তো এই লাইন পর্যন্ত বলতে হবে। হ্যাঁ, এই যে ডায়াগনোসিস কিন্তু এত বড়, জিনিসটা একটু মাথায় রাখতে হবে।
হ্যাঁ, তো বলছি ভাইয়া।
হ্যাঁ, ওকে, না আপনি ভালো বলছেন। হ্যাঁ, so I want to know the BP, এটা তো বলা উচিত। So there is a functioning, এটা কয়েকটা জিনিস তো খেয়াল করেন। there is functioning fistula, হ্যাঁ, এটা বলতে হবে কোথায় আছে, এটার লোকেশন। হ্যাঁ, মানে ESRD পেশেন্ট গুলোর ক্ষেত্রে মাল্টিপল স্কার মার্ক, মানে দেখবেন যে নেকের মধ্যে অনেক ধরনের স্কার মার্ক থাকে, ইন্ডিকেটিং প্রিভিয়াস ফর্ম অফ রেনাল রিপ্লেসমেন্ট থেরাপি, এটা একটু মাথায় রাখতে হবে। হ্যাঁ, এবং এটা আর হচ্ছে দেয়ার কজ প্রবাবল এটিওলজি। এখন আমি বাইলেটারাল ব্যালোটেবল কিডনি নাও পাইতে পারি। আমি if I find that there is a insulin peak mark, then diabetes may be cause. So depending on the actually your feature, then you will say, because ADPKD is very rare. You can find that some patient has diabetic foot amputation, then you can comment on this. There might have some insulin syringe. Okay, you can comment on this also. So this is important. So ঠিক আছে আপু, থ্যাংক ইউ। এবার আমাদের লাস্ট টপিক, রেনাল ট্রান্সপ্লান্ট। লাইন কেটে যাওয়ার সম্ভাবনা আছে, তাই একজন প্রেজেন্ট করা শুরু করেন। কে করবে এটা? একটু কঠিন যদিও বা। কেউ করতে চান? ডক্টর তাসনু বাপা করেন। আচ্ছা, আমি লাইন কেটে গেলে আমি আবার লাইন দিচ্ছি, দেন উইল স্টার্ট এগেইন।